based costume projects in Brazil, and will talk to us about her work. She recently has a book published called The History Behind Science and the Science That Makes History in Healthcare Business, which actually very easy, digest, quite to the point book. So that's a great reading suggestion for me. She also has a degree in effective writing from healthcare in HMS, and to some of the questions about how do we start communicating some of this better. I'm excited that we're bringing folks to this field who also think about effective writing and ways to communicate. So we will now hear from her experience, and then we'll have time at the end for questions across the board here.
Okay.
Thank you.
Thank you very much, Mary, and thank you very much for having me. It's an honor to talk about what is happening in Brazil and really deliver this class, Value-Based Care in Global Health, a closer look at Brazil. And the Brazilians that are here, I hope that we can also discuss a little more and share what we are doing in our country with our classmates today. And I hope that you can enjoy and get inspired about the few things we have to tell. So, as Professor Mary already introduced, I'm an engineer, and I would like to come back for what Professor Mary just talked 2 days ago when she was explaining to her kids about the purpose of fixed healthcare systems. So you can imagine that people ask me a lot what an engineer do in healthcare system, because nowadays my life is totally dedicated to improve systems and work with health economics. Value-based healthcare is what I do every day. And as an engineer, I think that when I was doing my postdoctoral fellowship, I had a co-supervisor here from, at the time he was at the Brigham. He's an anesthesiologist, Professor Richard Urman. And all the time that I used the word redesign with him, he answered me, Anna, we cannot redesign what we have never designed. We need to build a new healthcare system. So as an engineer, I think that I work for building systems that can maybe not solve 100%, but improve the complex situation we have in different countries, different organizations. Is what I have done in my research, consulting, and also academic activities in Brazil, US, and Portugal, the 3 countries I work with more frequently. I have worked with a few companies, but this class was totally prepared for this course, and I hope that we can really enjoy this moment together. So a little about the agenda. I will start talking a little about Brazil, because I can imagine that not everybody knows about how our healthcare system is organized. And it is very important to understand what I will talk in the sequence. The first project is much more a very big project. We are working with private companies in Brazil that is dedicated to really structure an integrated practical unit for preventive cardiovascular disease. The third point, I will talk a little about TDBC. I have developed several TDBC projects, and Professor Bob is an inspiration, and I have the honor to have a few collaborations with him on that. So it's very special to be here with you talking about TDBC. And finally, a few take-home messages that I think that are important before we close this afternoon. So, do you have any thoughts about the Brazilian healthcare systems? Nothing. Oh my gosh. One Brazilian who talks something, just for we start.
I'm married to one. So 20 years in Brazil, and they're always in the hospital. But they come out alive, so it's great. And my husband doesn't have to go visit, so it's wonderful. But yeah. But thank God we've never been in one, but everybody's around them and seem to, I mean, the care, it seems to be like quite good. They've been there for COVID and dengue and
a lot of specific disease in our countries.
Yes.
Dr. Chagas, super recognized. Please, Dr. Victor.
Right. Brazil is 212 million people, and every citizen has a public universal coverage under the public system. The public system is well organized in primary, secondary, tertiary care, but it's underfunded, and they took very seriously quite a few lines of care made to grant on solid organ transplantation, vaccination, maternal delivery, and there are a bunch of good things that are done there. But in 5% of the population have private insurances that are mostly paid by the employer. And that creates a huge disparity in our system. What the private patients get from their system is completely different. The inequity is huge. In the oncology field, for example, we don't offer immunotherapy yet in the public system. So we have really different realities. And many Brazilians dream to have a private insurance if they can. That's it.
Okay, thank you very much, Victor. You already introduced a few of the numbers that I would like to consolidate here to start. But yes, we have the biggest universal public healthcare system in the world. I think that this is something important, and we really we are glad about that. However, the budget for 200 million people is 40 billion US dollars. Only if we compare with the United States, it is a huge difference, and we really need to manage health population with this budget. Well, we already talked about the huge population we have, and it's not only big, but with several ethnicities and cultures. So this is another challenge we need to deal. And here, the point that Peter was just pointing out, most of our population are exclusively under the public healthcare system, under this 40 billion US dollars, and the 24% that have access to the private healthcare system impacts 60 billion to our economy. So here we can have an idea about the disparity in terms of private and public systems that we are managing every day in our hospitals and clinics. Also, we have an inequity situation that is associated to technology in the system. We have two agencies, if you compare with UK, you have the Etges and the NICE to evaluate all technologies that access the Etges system. In Brazil, you have two. Conitec will evaluate the public, and ANS will evaluate the technologies that will be available for the private healthcare system. So here, we always are evaluating what people will have access in two different ways. This causes another equity and access problem in the full country. And finally, in terms of reimbursement, we are mostly fee-for-service, but in the last years, we have started to figure out a few risk-sharing agreements. And Dr. Victor, Dr. Aline are here today. They are behind this history, and at the end, it would be very nice we hear from them how it is happening in a very important cancer center we have in São Paulo, that is Camargo. So, under this context, what does value really mean? We are discussing what value really means since Monday a lot, and I'm totally right that what we are looking for is to really increase health with financial accountability is what I wake up every day and work for. But in all the projects that we have designed implementing value-based healthcare, it starts a lot with a very strong strategic leadership. So when on Monday you arrive at the hospitals and companies that we work, the meeting with the CEO or your partners as leaders, I suggest that could start with how we design a strategy to increase value in our department, in our organization, in our healthcare system, if you are in a position that is looking for a population in the position of a Minister of Health. Once you have the leadership and this strategic plan, then it's much more ask the engineers about how you measure outcomes, how you measure costs. The DBC works pretty well, but we can also use another methodology when it's necessary, and you can merge, you can create different alternatives to evaluate costs. The prompts I showed yesterday, Jennifer was here sharing with you that we already have a lot of standard sets. We just need to really create plans to implement that. And once you have data, we are able to establish risk-sharing agreements, bundle payments. We can really create methodologies and agreements across different stakeholders that can contribute to reduce the inequity. We can increase efficiency in the healthcare system, and we'll generate more alternatives with the same money that can provide preventive care, can really increase health to our population and not focusing only on treatments and highly expensive technologies. So how we are doing this kind of things, and this is the focus that I would like to achieve today, is really working in a very integrative way. We are co-creating process involving different stakeholders and always thinking about the full care cycle. And this is super important because when we are talking about breast cancer or the cardiovascular disease that I will focus in the sequence, we are not concentrating only in the surgery or only on the technology. We are trying to really design the full care cycle since the prevention until the follow-up over the life when it's necessary. And under this contest and aiming to improve population health with financial accountability, we started to apply the value principles, and the CIFI-PRO emerged. The CIFI-PRO is a national collaborative effort that we are working on in Brazil involving several important companies to address this challenge. This is a project under the cardiovascular contest. With our huge population, you can imagine that cardiovascular diseases are responsible for an expressive number of deaths yearly in our country, and stroke and heart attacks are behind the most expressive numbers of these clinical conditions. Also, is a condition that we know very well, the risk factors. LDL, blood pressure, tabagism are very recognized and consolidated clinical risk factors that we can manage and we can better control, and it results in better outcomes. So all the project was designed involving several stakeholders with the objective to reduce the incidence of second major cardiovascular events for patients that already suffered a stroke, already suffered a heart attack. What we want at the end of the day is that those patients do not suffer the second, the third one, and die in the fourth or the third one. So to do it, we worked in a very co-creative process, following this methodology, the leader framework that we created at the first time in a project in Latin America involving 10 different hospitals from 8 countries to evaluate costs and redesign stroke care batteries. And during this project, we validated this framework where we start by leadership. We start by really aligning the goal and the purpose of the project with the clinical leaders, and the clinical leadership here is extremely important because it's who really engage the teams and make things happen inside the organizations. After that, we start to design the clinical framework and all the clinical map of the activities that should be delivered for patients under a specific condition. And once you have this process map, as Diabetes has for diabetes, we really start to redesign the agreements across the stakeholders. And these agreements are the start point where we achieve new bundle payments that will be consolidated and built based on very accurate data that we, at this time in this project, we designed all the governance and the technology required to collect the data for problems and costs that we will figure out on these new reimbursement strategies across the stakeholders. So the secret that we understand that we really are applying by using this framework is that since the beginning we put together all the stakeholders involved, and we are just talking about trust a few minutes ago. And in my opinion, when we started this project, we invited each company, providers, payers, the pharmaceutical company here involved, and we opened the objective of the project with everybody, and we respected the strategic objective of each company working in this collaborative initiative to our country. We never arrived in one of these companies saying, oh, we should do that, we should follow this clinical guideline, we should measure this. We really tried to adapt and integrate the strategies from each company to build the project. So who we are, we as PEV here, we worked as scientific consultants in this initiative. Novartis was the company that invested all the money to develop this project, was founded by Novartis. And as providers, we have three big companies. We have here Juliana from DASA. DASA is a huge hospital in Brazil. Amil nowadays is not only provider, but also payer, but a few merger and acquisitions happened in the last year. Redditor is also maybe now more than 50 hospitals across the country, so are big companies. And in the payer side, we also have three expressive accounts, and if we think about number of people under these 6 companies here are much millions. I don't know the number, but a lot, probably more than most of the European countries in terms of number of lives that are under those companies. So the first step, we designed the clinical map. And this clinical path here is where we defined the routine of care. How many consultations, exams that patients will be submitted over the year. And remember, a few minutes, maybe 1 hour ago, someone talked about how it is important to define the criteria, the inclusion criteria. And for those patients, this was very, very important because we are talking about patients that suffered a stroke. And those patients sometimes have several other comorbidities. So here we involved a lot of consensus across cardiologists and neurologists to define the inclusion criteria. And then we decided to define it based on the main guidelines. The protocol, the routine protocol over the first year, 2 year, the second year after the event. And also we created a framework to guide the goals. The goal for each metric, clinical and patient-important outcome metric that we expect for those patients over the first and the second year. Once we have it, we started to create this chiropractic governance strategy where we defined the indicators, the clinical indicators, the prompts that should be collected. And here just a parenthesis because we could, why did we just not included the ISHM standard set here? This is important to discuss. It's a question that we can talk later. But here we are involving patients that are under the stroke standard set, that are under the obesity standard set, that are under several standard sets. So we have this problem to manage here. And then we put together several special experts and we used the ISHM as reference, but we created a new one that could consolidate the main outcomes that should be evaluated for those patients. In addition, we looked for technology. So providers decided to develop internally in their digital healthcare systems. And the payers decided to hire a digital company to support all the measurement process here. This part I love inside this project because it's where we started to discuss the business model behind that. Because until now it's much more what should be done, what is the best clinical guideline, how can we measure, but here we start to discuss how we really make it happen in terms of agreements between the companies involved here, payers, providers, and the pharmaceutical company also involved. So 2 main models were created here, co-created with the companies. The first one was the B2C, that was much more adopted by the payers, and the payers here started a process to make a communication, much more proactive communication with patients, and the provider could be several providers, not only the providers involved in the project, but the payer at the first moment was much more communicating with patients to develop a preventive care and motivating patients with also a few financial benefits that they were providing for patients. And the providers much more were under this B2B model where they really are figuring out agreements with payers to offer this service to the society. Something new, something that nowadays patients do not have access in Brazil. Usually these patients have a cardiologist, a neurologist, but they do not have this integrated and preventive, proactive care assets. So these two business models were very important for the project because now it is really happening. We are already with patients under care, under CVPRO in different companies in our country. And what we expect for the next 1 to 3 years is the main goal that we expect to reduce major events incidents, and consequently this will reduce the costs associated with stroke and second infarct events that we can have in our country. Also, it's a landmark in terms of structuring reimbursement strategies based on value for preventive care in cardiovascular disease in our country. It's the first time that is happening, and especially in the private sector, involving big companies, and this is what we are now following for in maybe 1 to 2 years we can report in a good scientific article. So our few future perspectives about this project. The first one is very important. It was a very strong cultural shift. In all these companies, the cardiologists, when we started to open this project, they started the conversation with us, and it was something super new, something very different, and we had to work several months, much more, really explaining what this really means for the cardiologists and neurologists that work in those organizations. Also is a strong incorporation of digital solutions. And we hope that it can be just the first, and we can start to replace for other clinical conditions. And the good news is that it is already happening. Since we started this project, we are already working with different oncological care pathways, also for asthma in Brazil, and in Portugal, a very similar approach for obesity. In another angle, talking about the DBC, and the angle that I would like to bring for you today is how we are using the DBC to support the HTA process in our country. We already have a very strong classes about the DBC, so it's not my goal to explain how it works, but much more explain how we are using to improve the process to incorporate new technologies. So as I talked at the beginning, we have 2 agencies, but both of them, to submit a new technology, we need to prepare an economic analysis. So once our agency, Anvisa, that is similar with FDA, approved that a new technology can be used in our country, the companies need to submit, or the medical society needs to ask for CONITEC or ANS to put this technology available in the market. And when we do it, we need to prepare not only a clinical dossier, but an economic analysis. And most of the economic analysis use our fee-for-service and our reimbursement fees from the public system, not from the private. And the numbers are very small. Professor Nanda was just sharing the numbers from Africa. And here, a very quick comparison for a medical consultation, the reimbursement fee can be around $3 in the reimbursement fee table. And when you go thinking about the DBC, this will be around 25 in a public hospital in Brazil. So the problem to decide about new technologies using a very poor cost information in the model is that in 1 to 2 years, the burden is much higher than it was submitted in the dossier. And it's become a big problem for the hospitals. So how the DBC is helping, we have developed several DBC projects, and heart failure was a field that we really worked with maybe 10 students nowadays, and different levels of heart failure we already worked on, and a very expressive number of publications we have already done. And last year, the HeartMate technology, HeartMate, was under evaluation in our country, and the dossier was considering an annual cost for advanced heart failure patients around $800. While when we look at the literature, we can see that it varies around $20,000 to $60,000 international dollars. So it was not fair with the government that was doing the analysis and the consequence that will figure out to our healthcare system. So I mean to provide much more accurate cost information. We developed the TJPC for those patients, and we measured that those patients in a public context in Brazil accounts for around $45,000. And using that information, very positive result. The technology was incorporated, and now patients are receiving HeartMate in Brazil in 5 different hospitals. We did a very similar approach for several heart disease. Always we do the project, we publish the paper, and the paper is used in the HTA process. And nowadays we have already a few histories to tell about technologies that were incorporated in our public healthcare system. So, based on that, a few take-home messages, and I will finish with a few questions also for you open the Q&A. But first, the value-based healthcare principles, tools, and strategies are contributing to the healthcare system transformation, also in low and middle-income countries. I think that this is a message that we would like to bring today, Professor Bob, Professor Nanda, and myself. Evidence demonstrates that strong and effective preventive care centered on the regional patients' needs are followed by integrated care is valuable, resulting in better outcomes with financial accountability. Potentially, low and middle income countries are the countries that need it most to scale this strategy. Value-based healthcare can support HTA process and contribute to making decisions more oriented to our full care cycles and not only technology-based that we are discussing a lot this morning. And high-income countries and low and middle-income countries are struggling to establish more effective and sustainable healthcare systems. Measuring and applying strategic science to build new stories is necessary and feasible in both contexts, but requires at least high-level education. Here you are, leadership, here you are again, and fair policy. This is also important. Challenges. Do you have an idea about challenges that we are dealing in both contexts, the projects that I just shared?
Data.
Data, yes, very important. In Brazil, we don't have the data sets you have yet. Another one.
Resistance limit.
Sorry?
Resistance.
Resistance?
Change of resistance.
I think that we have, but in the experience I had in Portugal, for example, much more than Brazil. I don't know why, but maybe our colleague from Portugal here. An idea about challenges?
Yeah. The easy answer is data, because we work at Prof, so it's an healthcare company that tries to solve that problem. But I mean, it's quite cultural, I think. It's an easy answer too, but I think it's really
Okay, so I will put two here that I see as very, very important. The first one is a little associated with resistance, but in my opinion, there is a huge lack of knowledge on value-based healthcare, and we have a lot of commercial projects in value-based healthcare that doesn't help. So I do believe that this course, other courses that really disseminate what value really means. You, at the end of the day, want to improve health, and you want to do it with financial responsibility, accountability. This is extremely important to avoid the bad dissemination of the concept that was not introduced to the world to sell only focus on the financial aspect or new payment models. Is not what we're looking for. And the second question that is associated with the challenge is who should lead the transformation? I think that early morning today we talked a little about the role of governments, the role of leaders, the role of physicians, the role of patients, and each company involved in this process. I think that this is a very good question for discussion. In Latin America, something that happens a lot is this, and I think that Africa as well, big companies, as here I talked about the Etges, the HeartMate was founded by Abbott. In the PDABC about carbon, I saw that Professor Kaplan was telling about a project with BD. So different pharmaceutical companies involved in provide investment on this kind of projects. It is correct, it's the best, I don't know, but it is happening in Latin America, and I don't see happening a lot in the US, in Europe, different region of resources in the European projects. The Portuguese projects all are funded by the European commissions, and a lot of money that come from this place. The another one, what is the role of each stakeholder in this process? Payers, providers, patients, the 8 Ps, several Ps we can have. And the main question, I think that today is Thursday, Monday is each day closer. What is your role? And to finish, on Monday, I think that we can start the process to do something regionally, because we already have few histories in Brazil that did it. Sabrina Bernardes is the value manager officer at Hospital Albert Einstein, the most famous hospital we have in Brazil. She attended the seminar in 2020, and Einstein has a lot of ISHON standard sets already implemented, and they are now accredited by ISHON as well. Gustavo Arliani also attended 2020. He is behind Prepping Senior that created the first bundle for elderly patients in the orthopedic field. Here we have Dr. Vitor, Dr. Larini. Dr. Vitor is the CEO from Camargo. Camargo is using ISHON standard sets, and for me, the most important aspect, they are behind the first risk-sharing agreements based on outcomes we have in our country, and later they can talk much more and much better about that than me. And you can see that I have talked a lot about we. I have worked a lot with Dr. Carisi Polanzik. She was my supervisor, as academic supervisor, a friend, and is also my partner at PEV. And we work with these consultant projects, and also at Hospital de Clínicas, our academic hospital, where we develop most of our research in value-based healthcare, TDHC, and health economics. So thank you very much.